So today I'm going to be speaking about the role of Impella in high-risk complex PCI. And we're running a major large-scale trial, Tech 4, to examine the safety and long-term effectiveness of the strategy. These are my relevant. So more and more PCIs are being performed for what we call CHIP, complex and high-risk PCI. And CHIP is said to exist when there's three overlapping of patients. One, we usually have a patient that has multiple comorbidities. Elderly patients, diabetes, prior cardiac surgery, recent myocardial infarction, or heart failure, often renal insufficiency, and the patient with very high surgical risk or a turn down for surgery. Second, the patient has complex coronary artery disease. And I don't need to tell you what that is, but it's at least intermediate or high syntax patient. And then third, there are patients who have left ventricular and or right ventricular compromise with a reduced left ventricular ejection fraction, high blood ventricle, increased left ventricular pressure, pulmonary pressure, etc. So abnormal hemodynamics. And when we have to do PCI, this patient, this is the CHIP patient, we're doing more and more of these cases, and the outcomes are not going to be like this. The question really that arises is, we do perform these procedures with mechanical circulatory support, either of mild intensity, such as an intra-aortic balloon pump, or even more severe, such as Impella transcatheter flow support. So what is the outcome? Well, perhaps the most contemporary database we have called the Optimum. And this was a recent study from the United States in which PCI was performed in 126 patients who were turned down for bypass surgery in 21 United States hospitals. This was a prospective study. So these were surgical turn down patients. You can see the mean age was 70 years, more than half had diabetes. About 40% of the patients had acute coronary syndrome, and the mean left ventricular ejection fraction was 42.6%. So decreased, but not terrible. And this slide then shows you reasons for surgical ineligibility. There has to be a formal note that is consulted on the patient, and that was the treatment of choice, and the surgeon applied. Usually because of disease with poor distal targets, the very severe alveolar function and non-viable myocardium, followed by lung disease, great frailty, prior sternotomy, advanced age, etc. If you look at the 726 83% of them were severely calcified, 80% were bifurcated, 57% were effusions, almost 80% were long lesions. The total lesion length, 34 millimeters, and the syntax score was 32.4. So right on the border of the high syntax score. Overall, there were 3 per patient. Left main was intervened on in about 38% of the cases. A CTO was 20% of the cases. Atherectomy use was very high, almost in 30 cases. And interestingly, only a quarter of these were done with any sort of hemodynamic support device. Intravascular use, 12%. So, the mortality in these patients, this is the best hospitalization thing. And the mortality in these patients was substantial. The in-hospital mortality was 3%. The 30-day mortality, double that. The 6-month mortality was double that. So 12.2%, 1 in 8 patients had died with 6 months. How did that do well, the SDS 30-day predicted mortality was 5%. So almost identical to the PCI. Same with the Euroscore on 30-day mortality. Now the surgeons who saw the patient, who often consider different parameters that are in the Euro2 scores, the mortality is really about 50% of 30 days with surgery. In that regard, he's better. Interestingly, we have a anti-BI PCI risk score, we predicted 0.7% mortality, and it was actually. So no matter how you look at it, these complex high-risk patients that were turned down for surgery have very high mortality. Nonetheless, it's these patients, because if you only look at their quality of life, clearly improved. So if you look at their angina questionnaire quality of life scores and their KCCQ heart failure scores from baseline to 6 months, they get markedly. One of the things that we do in this registry is that we don't do much revascularization as might benefit the patient. If we look at the score, which was 32.4, okay, our likelihood of syntax score after the PCI of 0, meaning complete anatomic revascularization, was only 11%, only 1 in 9 patients. And you can see the mean syntax score post-revascularization was 15. In fact, looking at less than or equal to 8, which is considered reasonable revascularization, that was only 34%. So we take improved patients of coronary disease, but we're leaving a lot of coronary disease behind. And there is a relationship in this study and other studies with the better revascularization extent and long-term survival. So, why would we consider mechanical circulatory support for high-risk PCI? What would be the potential? Well, first, hemodynamic support would ideally lead to procedural complications. Okay, obviously, for very low ejection fraction, for high pulmonary pressures, they're more likely to during the procedure, and if we reduce procedural complications, that should improve early outcomes. However, perhaps more important, if we're not having the procedure under a big rush, the patient is hemodynamically tenuous, we could do a better job of bleeding collection and stent implantation. Again, not having rush, we'll take the use of physiologic lesion assessment and intravascular imaging, and we can do a better job with more lesions, more likely to get complete revascularization, and this should improve outcomes. It should not only reduce stenosis and stent thrombosis, but it should also improve left ventricular function recovery. And this should lead to overall reduced MACE, heart failure, arrhythmia, hospitalizations not only for hypertension, but also for heart failure, arrhythmias, etc., and improve quality of life. In addition, using data that mechanical circulatory support may have renal protective effects, which could reduce kidney injury acutely and lead to long-term renal preservation. So this is all need real data. Obviously, mechanical circulatory support is another puncture. Some of these devices are large devices, and they have their own unique tested complications. But we have to prove in randomized trials that the benefits outweigh the risks. And in that regard, a variety of different types of mechanical circulatory support devices. Some of these support the ventricle, some support the left ventricle. In the case of VA ECMO, it's both the right and the left ventricle. These devices are different sizes, of different mechanisms. They have different effectiveness in supporting the heart, and they have different risk profiles. So each one has to be studied separately. If you look at what we look for mechanical circulatory support, we obviously need to support the circulation and systemic perfusion, i.e., we need to preserve or increase the ventricular pressure. We would like to unload the left ventricle, so decrease high left ventricular pressures, and we want to perfusion. If you look at the hemodynamic support, balloon pump, Impella, ECMO, and tandem heart, they have different hemodynamic criteria in these three different goals. And balloon pumps, all three, don't really decrease LV, slightly decrease LV pressures, will support the arterial pressure somewhat, and slightly increase coronary perfusion. Impella probably perfect hemodynamic profile. It is very potent, especially with the CP, of supporting mean arterial pressure and loads the left ventricle, volume pressure, and it increases coronary perfusion. VA ECMO is good mean arterial pressure. It actually increases left ventricular pressure. If you don't use another device to unload the left ventricle, and it does no good. And tandem heart be good hemodynamic profile as well, but is not well. If you look at the two that have really been considered for mechanical circulatory support during high-risk PCI, as opposed to cardiogenic shock, it's really balloon pumps, as you see on the right side. So, what's the evidence? Well, we have one trial of an intra-aortic balloon pump in high-risk PCI. That was the BESIS-1 trial, which was more than a decade ago. This was 301 patients with left ventricular ejection, less than equal 30%, who had extensive and before they were randomized to balloon pump versus control. The primary endpoint was they could reduce in-hospital complications. Okay, so pretty low hospitalization. And there was absolutely no difference in MACE with balloon pump control, nor was there any of the individual endpoint making up the MACE endpoint. If you look at secondary outcomes, there actually an increase in bleeding and an increase overall in complications, access site complications. Although there was a decrease in procedural complications, mostly procedural hypotension, and there was about 12% of the affected patients who had to cross over receivable because of those procedural complications. So again, procedure a little less complicated, but there wasn't even with an 8-French balloon pump in terms of bleeding and vascular complications, and it didn't affect overall in-hospital MACE rates. Now, interestingly, when we followed these patients for 5 years, this was not a problem. But when we followed the patients out for 5 years, in the patients who had performed a balloon pump. And this is unexpected, not powered. You can see it was a 34% reduction, p-value of 0.03 times, so borderline p-value, significant. And it's not clear what happened, because the procedural success rates and the extent of revascularization overall were similar in the two arms. But nonetheless, keep in mind, even though there was no difference in MACE and early outcomes, all-cause death was better at 5 years. Nonetheless, though, for the primary endpoint, balloon pumps were not adopted as a routine use for mechanical circulatory support in high-risk elective PCI. And again, this is not cardiogenic shock for the MRI. That's another talk for the other day. This is elective or urgent, not shock, high-risk complex PCI. Now, what about Impella? Well, there's only one trial to look at with Impella, and this was the PROTECT-2 study. And here, in the United States, there was still a lot of balloon pumps being used for high-risk PCI. This was also about 10 years ago. And so they randomized 448 patients who had either a last remaining conduit or an unprotected left main with an LVEF less than or equal to 35%, or triple vessel disease intervention with an LVEF less than 30%. And they randomized the 2.5 device versus the balloon pump. The primary endpoint was a funny endpoint of major adverse events, both at 30 days and 90 days. And this was a lot of different events. Death, MI, using a very sensitive definition, stroke, TIA, revascularization, cardiac and vascular operation, kidney injury, cardiac deficiency, severe hypotension, ventricular angiographic failure. And you can see at 3 days, in both the intention curves on the left and in the protocol on the right, there's no difference between Impella and balloon pump at 3 days. But interestingly, from 30 days to 90 days, the curve can start to spread. A little reminiscent of what happened in the PCI trial where the balloon pump was controlled between 30 days and 5 years. Unfortunately, they only followed these patients for 90 days, not longer than 90 days. But you could see by intention to treat in 90 days, there was no difference, no statistically significant difference between balloon pump and Impella, whereas per protocol population, there were 21 patients who didn't get their assigned treatment. So if you just look at that population, should be considered secondary. Now there was a borderline reduction in the primary endpoint. They've gone on and reanalyzed the primary endpoint in a post hoc fashion to look at a kind of a more traditional mix. Death, stroke, MI, finding MI as either CPAD or troponin greater than 8 times normal, or repeat revascularization. And here you can see the curves. There was no difference for 5 days, then they start to spread, and by the time you get to 90 days, there was a significant difference in MACE between Impella and balloon pump. But this was post hoc, and the trial missed its primary endpoint. Now, that was the Impella 2.5 device, and there was a lot of vascular complications with that device, even though it was only a 10 to 12 French G. We since have the Impella CP device, which provides much more potent hemodynamic support. And once this was released, there were a lot of best practices that were developed to reduce bleeding and vascular complications, such as use of ultrasound-guided micropuncture and pre-close, and always using the insertion site into the cath lab so you could manage bleeding. And the PP was tested in the US Impella registry. And this was 1,104 patients undergoing elective PCI with Impella, 45 sites, 2017 to 2020, so relatively contemporary. And what they did was took 504 patients from this PROTECT 3 registry who met PROTECT 2 criteria, and they then compared to PROTECT 2 Impella. So you basically comparing Impella 2.5 in PROTECT 2 to Impella CP in like patients in PROTECT 3. And you can see some of the baseline characteristics here. You can see that the syntax scores were actually relatively similar, but you can see that there was much better revascularization done in the PROTECT 3 study than in PROTECT 2. So the so-called delta syntax score, or the amount that was removed, was 15.7 points in PROTECT 2 versus 21.4 points in PROTECT 3. You can see the same thing with the Jeopardy score. There was a greater relief of the vessels causing ischemia in PROTECT 3, PROTECT 2 like patients in PROTECT 3 compared to PROTECT 2. What about the in-hospital outcomes? Well, the overall case rates were lower using the Impella CT. These are now in-hospital outcomes using Impella CT than the Impella 2.5, PROTECT 3 versus PROTECT 2. There was no difference in death, although there was a trend a little bit with death. The biggest difference was the difference in myocardial infarction. However, this you got to take with a grain of salt, because in PROTECT 3, they had different definitions of what an MI was, and they weren't required to assess biomarkers like they were in PROTECT 2. So I would throw out this endpoint. I don't think this is a reliable endpoint, although every other endpoint was reliable. So, no difference in PIA. There was less vascularization, p-value of 0.06. Interestingly, despite using the bigger Impella CP device with a bigger 14 plate, using the better clinical practices to manage the access, there was a borderline reduction in vascular complications requiring surgery. That was really good to see. And a marked reduction in requiring transfusion. No difference in acute injury, although trending in the right direction. And with the more potent LCP, there was much less hypotension during support and much fewer being CPR or treatment tachycardia or ventricular fibrillation. So, better revascularization, fewer procedural complications overall. We're not sure about myocardial function. What did this do to long-term outcomes? Well, here are the 90 comparing the two cohorts, and I landmarked this at 3 days because I don't believe the peri-procedural myocardial infarction, and therefore the MACE rate within 2 days. So let's throw all that. But let's look from 2 days to 90 days, and now you see there's better outcomes using a CP device, like patients from the Impella Protect-3 registry, compared to the Impella CP 2.5, the 2.5 treated patients in Protect-2. So this is favorable, but this is a matched population, not a randomized. So what's actually being done in the United States? So this is our best data from the CAF PCI registry. It only goes up to 2018, and overall, 2 million procedures undergoing elective PCI for all stages of CAD, excluding shock and excluding NYHA4 patients. Only 0.3% had prophylactic MCS, either a balloon pump or other, which is mostly Impella. And if you look what happened over time, it went from 0.2% in 2009 to 0.6.7% in 2018. And in 2009, it was slightly more balloon pumps. Balloon pump use for high-risk support is sustained. Impella use is what's driving a slight increase. But it's still only 0.7% of patients. Very, very few. Who are these patients? Mostly unprotected left main disease, occasionally high-risk atherectomy where you're worried about no reflow, and occasionally very low LVP. Now, there are some sites in the United States where they're doing more high-risk PCI and use more MCS. So, for example, the VA system gets the Veterans Affairs, that's the military system, hospital system in the United States, gets predominantly elderly men with really severe coronary disease. And if you look over a 12-year period from 2008 to 2018, their likelihood of performing high-risk PCI was 8% to 12%. And their MCS use overall went from 3.2% to 11% of those patients. So still 90% of the high-risk patients are not getting support. They're just doing it, with these devices on standby. When they do use support, it's about 50%, 58% balloon pumps, and 42% Impella. So not a lot of data, not a lot of MCS used for elective high-risk PCI. So what are the guidelines? Well, the 2021 ACC/AHA SCI myocardial vascularization guidelines say that in selected high-risk patients, elective insertion of an appropriate hemodynamic support device as an adjunct to PCI may be reasonable to prevent hemodynamic compromise during PCI. So it's all about structural outcomes, but this is a Class 2B level of evidence B recommendation. So Class 2B, barely something that you should consider. And in terms of which trial to use, they just comment on balloon pump versus Impella, and they note that the Protect-2 trial was halted for futility after an interim analysis showed no benefit in the primary endpoint of MACE. That's true. Compared with balloon counterparts, they show Impella provided better hemodynamics. What about the European? The ESC guidelines are more comprehensive and easier to use than the US guidelines. And in recent ESC guidelines and any other ESC guidelines that have ever been published, there has never been a mention of mechanical circulatory support for high-risk non-shock PCI. They've never even considered it. So this is basically use. So with this in mind, we're performing the Protect-4 trial. And this is a large vision study. We're taking 1,252 patients with chronic coronary syndrome, non-STEMI or recent STEMI, with a core lab group with left ventricular ejection fraction of less than or equal to 40%, undergoing complex PCI. It's got to be either PCI, just a left main bifurcation, multi-vessel PCI with triple vessel disease, last intermediate vessel For acute vessel PCI, both complex. The patients have to be seen by a heart team and rejected for surgery. And then they're randomized 1-to-1 to an Impella CP device, or rarely a 2.5 is allowed in very small patients, to a control arm. The control arm could be a balloon pump or no mechanical circulatory support, and that can be a decision that the site made, which is stratified prior to the randomization. Patients are followed 1 month, 6 months, 12 months, 24 months, and for 36 months. They have a lot of testing. They have baseline bacterial echoes through 36 months to look at recovery of LV function. They have multiple assessments of KCCQ, Seattle Angela questionnaire score, 6-minute walk distance, NT-proBNP, and biomarkers, and more. Our hypothesis is that by providing hemodynamic stability during high-risk complex PCI, Impella will facilitate improved stent optimization and more complete revascularization that will translate into improved early and late outcomes. The primary endpoint is not a short-term endpoint. It's the composite rate of all-cause death, stroke, durable LVAD and heart transplant, myocardial infarction using high definition, or any cardiovascular hospitalization at 3 years. Assessed when the last person enrolled 1 year follow-up. So it's a 3-year primary endpoint. We also have multiple major sub-studies. We're doing a right heart catheterization sub-study to determine the effect of right heart catheterization variables, such as blood pressure, PA pressure, SpO2, et cetera, on prognosis, and for whether or not it's to wean the Impella CP by a protocol defined by right heart hemodynamic profile to determine patients safe for weaning. We have a renal function study where we are assessing renal function not only in hospital, but also as an outpatient for 5 days to capture all acute kidney injury. And we're also looking at long-term renal function at 1 year, 2 years, and 3 years to see if there's a reduction, an increase in acute kidney injury and long-term renal function in patients randomized to Impella versus control. And then finally, we have a viability substudy. We're performing cardiac MRI at baseline in 6 months to determine whether patients with viable or non-viable segments should be revascularized and what the outcome of those patients are, and whether or not there's a difference in outcomes with Impella versus control, but baseline viability. It's an on-service PI of this trial with Stefan Winter from Switzerland as my co-PI. This is an international study that's being performed at over 100 sites. Abiomed is the sponsor. And we're pleased to say that as of this date, 955 patients have been randomized. So we are in the home stretch of this trial, and in several years, 2 years probably on the outside, we should be able to get you the results from the PROTECT 4 trial, which is a definitive trial to tell you whether you can improve early and late clinical outcomes, quality of life with Impella CT support during complex high-risk PCI. Thanks very much.